Okay, I believe we are live. Welcome to NRAS Facebook Live. Thank you to my colleague Ariba that's making sure everything's working smoothly. If you can let me know, Ariba, on the chat if I'm coming across loud and clear and everybody can hear me. Um, we haven't done a Facebook Live on COVID for quite some time, so we thought it's time to just touch base again. And I am delighted to be welcoming Dr. Lizzie McPhee after a very busy day in clinic. So she rushed home to be with us to give us an insight into her expertise and some knowledge that she has around what's been happening in the world of rheumatology, specifically around RA and, of course, the vaccines and everything. But we do have some other questions that have been coming in as well. You do have an option if you want to put a little question or a comment in the chat. My colleague Ariba will be monitoring that. And if we can get to your question, we will try our very best. But we do have quite a number that we had already had submitted. So we'll crack on because I'm sure Lizzie's ready for putting her feet up. But thank you, Lizzie. I really appreciate you taking the time out of, as I said, your very busy schedule. Um, so, first of all, do you want to introduce yourself to those who might not know you as one of our advisors?
Yeah, so I've got my badge on. It's not showing up very well, but I've got my badge because I'm one of your new NRAS medical advisors and very proud to be part of the team. It's a fantastic role that NRAS play in supporting our patients, and we've really, really, truly valued their support throughout the pandemic because we know patients have really struggled to get in touch with teams because of redeployment and such. And hopefully, lots of us are in a better place now. But yeah, we've really, really valued the support of NRAS. So thank you, from the rheumatology community. So I'm a rheumatologist up in Preston, in a community-based service, and I very much am a jobbing rheumatologist, but I do have some other hats, and I am chair of the clinical affairs committee for the BSR. So I've been very much involved with the guidance that the BSR have been drawing up to support our rheumatology clinicians, consultants, nurses, etc., and working very closely with Claire and the team at NRAS to make sure that what goes on your website aligns with what the BSR are producing, which aligns with what Versus Arthritis are saying. So we've been working really collaboratively, and I think that's been, one of the things that we've seen. The collaboration has been fantastic over the pandemic, and it's just a privilege to be back in the hot seat. So
Back in the hot seat, indeed. I mean, you have definitely got you in the hot seat because there's some super questions coming your way. But just to comment on that, it has been COVID has actually given us a great opportunity for collaboration amongst so many organisations that perhaps we didn't work as closely together before. So every cloud and all that has a silver lining. But I'll crack straight on with some of the questions that we have this evening. We've been getting lots and lots of questions about antibodies and people doing home antibody tests and then of course not always getting the result that they thought they were going to get and worried that how can they tell whether what after having the COVID vaccine that they are protected. So just really wanted to get your views on that.
yeah, so I will give a very personal example that I came into work 2 weeks ago to find a printout on my desk of one of my patients who'd had a private antibody test and asking could Dr. McPhee just give him a ring to explain the result. So you can imagine my horror. So one of the challenges that we have is there have been antibody tests rolled out to understand the impact of COVID-19. Probably the best example is about 2 or 3 months after COVID struck in March last year. You probably recall that there was lots of us within the NHS had our antibodies tested, and it was a part of a study of NHS workers to look to see how many of us had been exposed to COVID to get some ideas about the impact going forward on NHS workers and such, and also to get a feel for how many people, working in hospital settings were getting exposed, maybe hadn't been aware that they'd had an infection and such. So it was a big piece of work done across, and I had my antibodies checked at that time by the hospital with a test that had been approved and checked by our hospital lab as being a robust test that was going to give us a reliable result. Um, and we have been testing the occasional patient to try and determine whether or not they've been exposed to COVID when we've been struggling to work out whether symptoms might be still related to a recent COVID infection. So we have been using antibodies in the NHS for particular reasons to understand, as I said, whether people have been exposed, and to help some patients who might be struggling, to know whether ongoing symptoms might be related to a COVID infection or some other illness, not rheumatoid arthritis, but other illnesses that we see, particularly in rheumatology clinics coming through. And so they are available, but what we don't know is how to use them in the context of assessing response to the vaccine. And that's really important to understand, because one of the things in medicine is there's been lots of questions over the last year we haven't known the answer to. And what we've got to be careful about is how, when we do tests, then how we interpret them. And so there is no good understanding at the moment about when you check antibodies, what the result means, how long those antibodies stay for.
Hmm.
And so we are very, very careful about how we use these tests without an understanding about what we then do with the result. So there are some studies going on looking at patients who've had the vaccine where they are checking antibodies and seeing that people are mounting a good response and such. So they are being used in certain settings and understanding, but in the general population, we don't have access to these tests for this purpose.
Hmm.
I think the challenge then is, my patient had gone off and paid for and had a private test and sent off a sample of blood and then come back. My problem, and I said this to my patient as we discussed the result, was that I don't know the validity of that test. So I don't know how reliable that test hasn't been through
Yeah.
my laboratory locally and told me this is a test we are confident for use, it passes the standard, and we're happy for you to use it. And that's so every test, every blood test that I send to the hospital, I know that my lab has done the work to make sure that that's a good
Hmm.
quality test and I'm getting a reliable result. That's called what we call validity. And the problem with some of the private testing is we don't know quite how robust those systems are in place. So I had to be very honest with my patient to say, I don't know how reliable this result is.
Hmm.
So, I mean, everybody is a grown up and everyone has their own options. And if you want to send off your blood or pay to have a private test, and then I'm not going to stop you. Everyone, can make that decision for themselves. But I think the difficulty is we may struggle to give you the answer as to what that test means, in the context of what's happening.
Exactly. And
Um,
I was on a call with the vaccine minister there last week, and there was a GP that's part of the vaccine task force, and he was also saying that even GPs haven't got that knowledge to be able to fully understand blood tests when they come back around these antibodies. Then
mm,
they're not necessarily sensitive enough,
yeah.
especially the home tests. And of course, what they're not showing is the T cell response.
Mm.
So, I would probably urge people to not do home antibody tests because it's not going to be sensitive enough. But we do know that there is a level of protection that I've got my vaccine, I'm now protected by how much, and it does vary. So there's a lot still to understand.
I
So
think, Claire, just coming back, I think one of the worries for us as well is that somebody may get a result that they think, oh, well, that means I've got antibodies and I'm okay. And then, but we don't know how long they last. So I think for some
yeah,
patients, it may give a false reassurance, or people might say,
mm,
well, I only had that blood test done, so I don't need that booster vaccine.
yeah,
And so I think there are just so many yeah, unanswered questions that
yeah.
so.
And I think, many people listening tonight will have had at least their first vaccine, and if not, have both. But still, the message is, for those that were classified as extremely vulnerable, if you can work from home, do work from home. Still keep that social distancing. It doesn't mean that it's, all's back to normal. whatever back to normal actually means. I never know. But I think it's I having both your doses. I think that's the clear message. So somebody's here is asking that recently diagnosed with rheumatoid arthritis, and if you're watching, whoever that is, please do get in touch with us. We've got a great new to RA pack that we can send you, and started hydroxychloroquine and steroids. So I've got my second COVID vax next week, but I don't know whether I should postpone until they've finished steroids. Because obviously, so because there is concern around steroid use, but I know when we were looking at the stratification of it was quite high doses of steroids. So could you give a little bit of explanation around that?
So this is tricky because I'm going to put my hat on. I don't know the age of the patient or other risk factors. Have they got
Yeah.
other medical conditions that might play a part? Ethnicity as well as something. So there's lots of other factors that might influence, the
Hmm.
level of risk rather than just thinking rheumatoid arthritis and steroids. So Claire, as you mentioned, the steroids. So the steroids were a risk um, as far as if you adding to your risk if you caught COVID of having serious complications, and you're absolutely spot on. It's about the dose and how long you've been
Yeah.
on them. So I suspect at the sort of dose that somebody might have a reducing course for a new diagnosis of rheumatoid arthritis, it's probably not going to meet that threshold, but it needs to be taken into consideration when you're thinking of that patient's individual risk. But the other challenge is that steroids dampen your immune system slightly, so they reduce your response to the vaccine potentially, theoretically. Again, we do not know the answer as to how much.
Hmm.
Then we've got the complication that if someone has got active disease, what we know for patients with rheumatoid arthritis is that the thing that increases your risk the most is having active disease. So if you were to catch COVID, that is the one thing that we know is the biggest influencer over lots of the medications that we've been worried about don't seem to be as much of a worry as we thought they might have been at the start of the pandemic. There's one standout, which is the good old rituximab, which I'd be amazed if we don't have a rituximab related question on
We
tonight.
do indeed.
But on the whole, what we know now from the EULAR register, so this was a register that's been collecting patients around the world, but we've had this our own register in Europe, the EULAR register, and what it has shown is that patients, the greatest risk is having active disease. So coming back to this case, I think my honest advice to this patient would be to just go on and get her second vaccine, because she's a newly diagnosed patient who's obviously must have active enough disease for them to give steroids. She's on a relatively low dose, which she's going to be weaning down. My advice would just be get on and have it, because getting as much protection as you can as quickly as you can is probably the most sensible thing to do.
Absolutely. And that kind of leads on nicely. There's a lot of talk about, should I, shouldn't I miss a dose of methotrexate, before the vaccine, after the vaccine, etc. And of course, that really will vary considerably because of the dosage of methotrexate, but also the how active the disease is. But so, as you said, it's more important to
Mm.
ensure the disease is as well controlled as possible. So again, from your patients, you've probably had some that have chosen to miss a dose and others that have any
Yeah,
different.
I've come across very few who've omitted. Lots of people have thought about it,
Hmm.
but lots of patients have thought and then gone, you know what? Or we've had phone calls through and we've been able to advise patients before, and it's a difficult one this. So and it's something that the BSR have actually produced some guidance for its members, for consultants and specialist nurses regarding, because when the vaccine started to be rolled out, it was the big question we were all asking, will our patients do better if we let their immune system have a bit of a break from the drugs to get a better response? And you can see the logic behind it. The
Mm.
vaccine relies on a healthy immune system to produce that immune response, um, and so therefore there is again the theory that if you stop your medication to let your immune system sort of come up a little bit and it's not dampened, um, then you'll get a better response. And there has been a couple of very, very, very small, and I would emphasize very, very small studies done looking at vaccine response to the flu vaccine in patients on methotrexate.
Hmm.
And one of those studies showed that there was maybe a suggestion that stopping the methotrexate helped get a better response. It was very, very small, and we've looked at this at the BSR to say, well, is this something we should be recommending anyway for the flu vaccine? And it is not good enough evidence to say.
Right.
So, and the difficulty is sort of putting that all across to the COVID-19 vaccine is that this is two vaccines. We don't know how long it's sensible to stop for. And the biggest worry, as I've already emphasized, is if you stop your drug and flare, that's actually the greater risk.
Yes. Yeah.
And we don't know. So the strong message that we're giving to our patients locally, which is in line with the British Society for Rheumatology guidance for our specialty, for our community, is that patients shouldn't stop their treatment
Yeah.
before or after their vaccine because it's more high risk for them that their disease flares. And then if they catch COVID, they could do worse.
Right. Okay. That's very clear, and that leads on, as you might have been, you already mentioned the question around rituximab. I've
Mm.
seen that we already had a question that had come in, but I also saw one just come in about rituximab as well, and just knowing about the gap, I suppose, to leave between having the infusion or having rituximab and getting the vaccine. So again, any because there is somebody that's quite concerned about that.
Yeah, so this is a really difficult one because if you're on rituximab and you're starting to flare and you need your treatment, you want your disease under control. So again, it comes back to that whole balance of controlling disease, which is the greater risk, and the treatment. But rituximab is a bit different because it knocks out your B cells, and your B cells produce your antibodies. So that's why it is more of a concern with the vaccine. What we did in our department was as soon as the vaccine was being rolled out, we were aware that not all of our rituximab patients would be in that clinically extremely vulnerable group. So we actually proactively contacted every patient of ours on rituximab, irrespective of how long it was since their last dose of treatment, and we got them into our vaccine hub for our trust. We were given permission, and I think it's fair to say anyone who offered who hadn't had it or wasn't in the system took that opportunity and just got vaccinated.
Hmm.
And what we said to patients is that, if their disease is starting to flare and they are struggling, then let's get one dose into them, and if possible, if they can hold on for a month, to wait a month so that their immune system just has as much opportunity as possible to mount a response to the
Yeah.
vaccine, then give them the rituximab. And then we just kept on course with giving them the second dose at the 12 weeks, which everyone was having. So that's how we've done it locally. We've brought everybody in. I'm aware that not every trust has had that luxury. We were very fortunate to have that. But I think my advice to patients, if you've not had it, your vaccine yet. I would have thought most rituximab patients would have had
I would
just
have thought so. Yeah.
but what we're trying to do is to sort of suggest holding off for a month. That's what the sort of guidance is. Now, obviously, there's the two vaccines. Well, if someone's starting to flare, you can't leave someone for 4 months.
No.
And there is very, very, very rare circumstances where people are allowed to have their vaccine a month apart. Everyone's got this 12-week window. I've not heard of anybody who's managed to get round that.
Yeah. There
Um,
is talk, certainly, and I'll come on to some information about the boosters that have been
mm,
talked about for the autumn, but also um, so as to get ready for the boosters to actually shorten. So some people that may be called back within 8 weeks rather than the 12 weeks if they've just had the first dose because they're getting ready, thinking ahead for the boosters as well.
mm,
So just following on from that on the rituximab question, somebody here saying that their GP said that most vaccines are only 60% effective. That's, not that particularly helpful. But so assuming then if they're on rituximab, that's going to be even less. But even if I know this is a personal view, but even 50% uh, protection is better than no protection.
Mm,
But we are seeing, and somebody else has asked, are there any studies around the vaccines and people with rheumatic diseases? And yes, there are. They're gathering data, part of the EULAR data. Again, you can see the links on our website to that. Um, but it will only be over time that we'll start to see these results, won't
yeah.
it, when analysing the data?
I know from the group that I'm involved with through the BSR, who sort of get together and draw up our guidance whenever we've needed to update that. I know that there was an email probably a couple of months ago now saying, is anybody interested in being a site for a study to look at vaccine response in rituximab patients and what's the best timing? So I know that there are people who are a lot cleverer than I am, who have access to setting up research studies, who are very, very keen to do some work to try and help guide us better with the decisions that we're making for our patients and the timing of things. And I know that they're taking shape at some big units up and down the country. Um, and as you know, a lot of the sort of red tape and barriers to doing studies has been lifted
Yeah,
during COVID. It's been, again, one of the positives to come out of the pandemic, that a lot of red tape has been removed. So I have little doubt that there will be little pockets of people doing some studies to be able to then inform us, and they will be, I'm sure, shouting about those once they've got some results to share, because
yeah,
it's those sort of studies that will really help us going forward. But I
absolutely.
think these quotes of 60%, we don't know. We
Hmm.
don't know. And I've said to my patients, it's better than, it must be better than. And actually, the suspicion is that it probably doesn't, for a lot of people, have a huge impact on their how much. Actually, probably age is the biggest thing that
Yes.
impacts on. And I think that's what everybody's forgetting, is that actually what we've now come to understand about COVID is that actually it's other factors that are probably more worrying: age, ethnicity,
Hmm.
other comorbidities such as diabetes in particular, um, being overweight,
Yeah.
that are far, far, far riskier than the drugs that we've been worried about. That's not
Exactly.
saying I don't want to give false reassurance,
Mm.
but it's a case, like you say, of thinking of the whole person. So
And somebody asked, saying, because they are immunosuppressed or immunomodulated, sometimes is another way of putting it, that they're trying to get their GP to give them their second dose sooner than the 8 weeks. But there is, I wouldn't recommend that to anyone. I don't want people rushing to GPs saying, I need mine sooner. It has all been thought out very well, and that is something actually I think we should all be
yeah,
immensely proud of. The vaccine rollout has been world class, and it's working, and there's a reason for the way that the ages have been done, and the different categories. So
yeah. So there's actually
don't put
this is
pressure on your GP is what I'm saying.
there's actually some really good science behind the extension
Mhm.
of leaving the longer gap, because just because the studies did it at 4 weeks, they did it at 4 weeks because these studies had to be done quickly. So they needed to do a two vaccine schedule as quickly as they could within those 4 weeks of each other. So that's why the studies were set up, one of the reasons, with that time interval, because we didn't have the luxury of, oh, well,
Mhm.
that's 3 months, because that means we wouldn't have had the safety data for another 3 months. But there is really, really good science behind the longer time interval and then boosting the immune system a little bit later. And actually, there's a very, very strong case being made by the scientists who are, as I will say again, are far cleverer than I am, that we've actually done our community a much better service by leaving it slightly longer,
Mhm.
because the immune system has been sort of boosted and primed, and then boosted at a slightly later date to even prime it further. So I know that there was a lot of controversy when that delay was announced, but it's probably actually is better science. And I know that
Absolutely
Chris
good.
Whitty explains this far better than I do. But I do say to my patients, please don't. And I know it sounds brutal, but you won't get it any sooner.
No, no.
Is the bottom line. So
Yeah.
please don't take up somebody else's phone call to the GP surgery or to the vaccine centre, or prevent someone else from getting through, or prevent a newly diagnosed patient from getting that GP appointment,
Mhm.
because you won't get it sooner, even if you ask for it, which I
Yeah.
know is
Yeah.
brutal to say,
And
but
it is difficult, and feel for all those people that are worried about going out and about. But, we've come this far.
Mm.
Please don't let us fail at this almost final hurdle. Um, just before we go off of the topic of rituximab, somebody who had an anaphylactic reaction to rituximab and has been told that some of the ingredients in the vaccine are similar, so of course concerned about, and just wondered whether you'd come across anybody had who had reacted to rituximab badly, but has had the vaccine and no issues or any issues.
So anecdotally, no, I'm not aware of any of our patients who've had a bad reaction to rituximab having any problems with the vaccine. There's very, very strict. Well, there's not very strict, but there's a lot of information in chapter 14A of the Green Book. So I've signposted quite a lot of my patients to
Yeah.
this, which gives you the constituents
Mm,
of what's in the vaccine and what are the components you might need to be worried about if you have allergies to any components. So that's chapter 14A, Green Book, and that's the Joint Committee for Vaccines and Immunizations. That's their
yeah.
Bible, and 14A is the chapter on the COVID-19 vaccine. So I have signposted a few of my patients to that when they've had very specific queries about the vaccine, because they just wanted to see, where's this information coming from, and you can look up and then see. And there are then there is again, I'm getting a bit medical, but again, I'm a great believer in empowering patients where to
Mm,
find information. For all of the drugs that we use, there is something called the Electronic Medical Compendium, the EMC,
yeah.
and that will
Where we go for all
contain,
our
yeah.
information too.
So it will contain, so if you
Yeah.
type in whatever drug you're on, rituximab and EMC, it'll tell you the constituent parts.
Mm,
And then that's how we decide as doctors, if you've had a bad reaction to a drug, you can look and see, oh, well, it contains A, B, C, and D. So, and this drug contains, so I would avoid anything that contains these components. So you
mm,
can, if you like, cross match between
yeah.
the two. Um,
Or you can, of course, always phone the NRAS helpline and we'll help you navigate that sort of level of information. And there is a link to the Green Book that Lizzie just talked about again on the COVID section of our website. Somebody's asking about a child, a 16-year-old with JIA being offered the vaccine, and I can probably offer you some information again from our discussion I had earlier in the week with the vaccines minister, and the question was asked about children, and the answer was the position in the UK is that we don't have enough information to approve vaccinations for the 12 to 15-year-old. Now, Pfizer vaccine has been licensed for 16 to 17-year-olds. However, in general, the younger are lower risk, but most immunocompromised children have been taken off of the shielding list, so their risk of COVID is also considered to be lower than adults. So I think for at the moment, whoever asked that question is probably not, but they are keeping that under review all the time. So there's still people looking at that. Any other comment on the JIA side of things? I know I don't
yeah,
believe you see many children.
no, well, we do see patients from 16 up, and we have a few
Mm,
patients who transferred across to our service, who are sort of, much younger adults, sort of wondering. But yeah, I think you're absolutely spot on. The risk in children of serious COVID-19 infection is very, very small. Um, but obviously, a child with JIA who's on a drug compared to a child without JAI and not on any medication is going to have a slightly higher
mm,
risk, just because, well, that's quite obvious just from them having a diagnosis and being on a medication. However, you know until I think there is good evidence and that the JCVI are happy with respect to the evidence that this is safe in children to give the vaccine, and those studies are rapidly happening at the moment, as you know.
yeah.
My instinct is that we will probably see secondary school children being vaccinated from September with the start of the school year, I strongly suspect that's going to. I've
Yeah.
preempted my or forewarned my two children that be ready because I think it's coming, guys.
Yeah.
And I think it will once we've got through the adult population. And it is a tricky one for these younger patients who are in school and such in contact.
Hmm.
Um, and it may be that there are some younger patients that get offered,
Yeah.
as we gather more information. I suspect it may happen.
Um, any updates on the Indian variant and whether it's, people with immuno suppressed conditions are at a higher risk of that, or is it again very similar? I suppose it depends on age and ethnicity, etc.
Yeah, so I mean, I know there's been quite a lot in the press. I work up in Preston, which you'll, if any of you know the north, and Lancashire is very close to Bolton, and we've had a few breakouts close by. So we're keeping an eye on it locally, speaking to sort of colleagues who work over in Bolton at the hospital. All of those who've been very, very poorly and admitted, most of them are people who were offered the vaccine, declined, opted not to have, and have got other medical conditions, a
Yeah,
lot of them, things that would increase their risk. So I think we've not got any signal as yet, but it's difficult. It's what these big registers are looking at, is whether there's any signal. So we're not picking up that our patients are at any greater risk
yeah.
with the Indian variant. Mhm.
And sometimes there are things that hit the news that can be quite, headline grabbing. So again, it's always looking for the profit. I mean, somebody has commented on a small study that's come out of the States about, again, going back to steroid use, and but again, it's, if you look at the full study, it's actually quite promising. So again, don't look beyond the headlines, I think, is guess what I'm trying to say, and we will be regularly updating our information on the website on the COVID section for any new studies that come out and when we have those available. Um, just change a question here, really, is about virtual consultations and getting back to face. Now, I know you're in the community more than a hospital setting, but what's been your experience of virtual consultation? When I say virtual, be it like this,
Yeah.
Zoom, or on the phone, and advantages, disadvantages, or
Yeah,
how do you see
so
that going?
I think without a doubt, if 18 months ago now, someone had said to me, you'd be doing all your appointments for the next year by telephone or online, I've said, that won't work. I think it has worked extremely well in certain situations. So I think for some of our patients, and I think without a doubt, we are going to see um, telephone and online appointments incorporated into our practice for the right patients in the right situations. And I think that's the really important bit to pick out. We were sort of forced to a telephone online mode of option to keep everybody safe, which was the right thing to do. But obviously, one of the big things we can't do over the phone or even online is to examine the joints.
Mm.
Um, I've just come back. One of the reasons why it was a bit of a dash was I had 8 follow-ups today, a couple of new patients. 3 of the follow-ups have all had 2 telephone appointments during the pandemic, and sort of reported, no, I'm doing okay. They came today with very active disease.
Mm.
And I said, "Oh, how long?" Well, I didn't want to really trouble you, and I've sort of just been getting on with it. I didn't really want my medication increasing. I've been worried, and absolute completely valid reasons and such. And it just makes me slightly worried as a clinician how many more
Mm.
patients have been, oh, I've been okay. And so I think without a doubt there is a balance, but I think we have to spend some time making sure that patients are given the options. And one of the things we're finding at the moment is that patients are sort of almost sadly for convenience saying, well, can I have a telephone? Because, well, I've not been able to get the afternoon off work. I've only just gone back and I'm struggling, or I've got the kids to pick up, or I'm looking after the grandkids now. So they've opted for a telephone. We ring them up and then they go, oh, I'm really struggling at the moment. I'm like, well, why didn't you come and see us face to face? Because I can't escalate your treatment safely without assessing you. So
Mm,
we've now built in some safety checks when patients ring to say, look, I'm not comfortable coming face to face. Can I have a telephone to say, look, do you think your disease is active at the moment? Are you struggling? Because if you are, please, please, please come for a face to face. Because all that happens is we have to say, okay, and then we have to book patients in as an
yeah.
extra or such. So I think we need to work in partnership.
Hmm.
And I think it's not about convenience for us and it's not about convenience for patients having telephone and online appointments if it's not the right thing for us to be able to make those decisions about the management.
Yeah. Yeah.
But if you are doing really well, know your disease well, and are stable, and are not worried that I say to patients all the time, you know your joints best,
Hmm.
then I think there will be a place in the future for telephones. But what we are mindful about is that we wouldn't want just series of telephone. Every so
Yeah.
often we need to have that sense check and things. And I think the patients have actually, they see a place for telephones, a lot of the patients I speak to, but it's in the right context.
Mm.
And
Because you lose some of that nuance of, like
oh,
the patient you were just talking about that, said they're fine, but now if you could actually see them saying that, you were like, are you though? Because
well, you just,
facial expressions can tell you an awful lot, and of course then you'd be able to
well, I was
actually
going to
see
say,
their
I
joints
was
as
just
well.
looking at these patients' hands today going, that is not well controlled disease. You've got
No.
swollen joints. So,
Yes.
it just didn't take much for me. And, I saw one patient walk through the door and I thought he normally plays golf. And I thought, are you playing golf? No, I can't play at the moment. And, so I think there is so much. And I think, God bless our patients. They've not wanted to worry us and trouble us and such. But, just work with your teams. If you feel your disease is active, I think it's very difficult for us to be able to escalate your treatment, start you on new medication
Mm.
without that actual assessment of your joints. And so, as a department and speaking to other rheumatology colleagues and the community, nurses, consultants, I think we all feel, we need to be assessing patients
Yeah.
before
Because
starting
of
those new
course, as we
treatments.
just said, uncontrolled disease, active, really active disease, it puts you at higher risk of COVID,
Mm,
vaccine or no vaccine. You're putting yourself at higher risk, but also making your job a lot harder because if it's much harder to get disease under control when it's out of control, but
mm.
when you begin to feel it beginning to flare or grumble away, you know, it's work, as you absolutely said, Lizzie, working in partnership. The sooner, if you can stop it when it's just
Yeah.
beginning to go out of control, it's a lot easier for you to get it back under control and
Yeah.
back under.
And irrespective of, COVID being around, telephone appointments and online appointments were going to come.
Yeah,
It's been rapidly
accelerated. Yeah.
accelerated and rapidly brought out. One of the things that we're doing, which it'd be lovely to just sort of have the opportunity to plug, is there's two things actually we're doing to support our patients. There's been a fantastic video released by the study group from Remora,
Yeah.
which teaches patients how to examine your joints. And we're asking all of our patients to watch that video. We send them the link and we do various other things. And then we say, please have a look so that you can really understand what we do when we examine you. And patients can then be trained up to examine their own joints. And then the other thing that we're doing is we've now got access to the BSR platform to get patients to do a DAS, to fill in those scores for us and to fill out questionnaires. So what we're looking at now is, so if we've got patients who are doing really well, it would be lovely to get them to provide information so that when we see them for that snapshot in clinic, we're not just seeing, that 15 minutes in that
At
whole
that moment
year.
in time.
We've got a little bit more information coming, and there's loads of work being done across lots of conditions, not just rheumatoid arthritis, about how we collect more information from patients to give us a better feel of how you're managing and how you can then drive that consultation. Say, you know what, I'm not doing as well because look, back in February, I filled out my scores and that's what I was like. And then June, I was a bit better, but August, I was flaring again. This is how many swollen joints. The
Mm.
power of that information and putting you guys in the
Absolutely.
driving seat.
Data is
So,
the thing that will unlock so many, um, future uh, treatments, or the way we treat the pathways that we follow as well.
So
Um,
virtual appointments will stay.
yeah,
Collection of information from patients to help us to help you manage your disease
yeah,
better will stay. And I think the other thing is there being sort of better access. So, patients who are stable, not just having appointments for the sake of having an appointment, of you accessing us when you need to. So there's something else coming called patient initiated follow up, but not removing any of the safety nets. People still have appointments, so you're not
yeah.
left without the backup of a rheumatology team, but you have better access to us when you need us. So I think keep an eye out. There's going to be lots of changes happening to teams, and what I would say is that COVID has just given us the confidence that we can do things differently, but it's not about then stripping back services. It's about
Absolutely.
actually having an
Working
opportunity
smarter.
now to
Mm,
redesign and work smarter. And if you have the opportunity to get involved in those discussions and help your team, if you see any questionnaires to say, please tell us how you're finding this or that, or the remote or the telephone, or how's the advice line been working, tell your team, get involved with those questionnaires, because we want to involve you,
mhm.
and we want to involve patients in those discussions. It's really
And
important.
likewise, NRAS is playing an important part in how rheumatology teams are getting back to a new way of delivering service. So again, if you see a request comes out from NRAS asking for people in a particular area to have their say and get involved, please do, because you can shape the future for your own treatment, but also for others as well.
Mm.
Just a few more questions that have popped in while we were talking about that. Here we have somebody who had flu, COVID-like symptoms for about 5 weeks after their first vaccine. Now, of course, we don't know whether you might have already had COVID before you had the vaccine, so you might
Yeah.
have had, but there's perhaps no way of knowing that. But nothing, they had no reaction after the second dose, which is good. And just wondered, is it because they're on a Bataset? But again, I don't think we have that level of whether that would have
Mm.
made any difference.
No, I wouldn't attribute any cause to being on another drug. I think what we do recognise is that aches and pains, muscles and joints are a relatively common side effect after both the Pfizer and the Oxford vaccines. We've had a lot of patients phone up and say, "Well, it flared my arthritis. I had problems," and but it's recognizing that it is a relatively common side effect. So we've been very proactive to say to patients, be ready with your paracetamol.
Hmm.
That's the best thing to take, and just be prepared. Just managing people's expectations.
Yeah,
Don't go and book a meal out the day after your vaccine. Just be ready that you might feel a bit grotty for a couple of days.
exactly.
Prepare yourself for it. Um,
So don't invite the mother-in-law around. That's the idea. Somebody's also, I think they may have missed this earlier, so I'll just repeat it. Somebody asking about, could we tell them that the percentage of, how protected they will be after the vaccine if they're on methotrexate and a biosimilar for adalimumab. Again, we can't, there is no hard and fast rule as to the level of protection, but certainly you will have a substantial level of protection. Um, so, it is so, so important. That is the key message, not just coming out from NRAS and BSR, but from EULAR, the big European organization as well. Uh, the vaccine will give you protection. It may be different to the person next to you, level of protection, but it will give you protection. It's so important to get that. Um, Let me see. There's a question here. Are there any antibody studies with immunosuppressed patients? Again, there is studies that are being done. Again, you can see all the links to all the various different ones, and some are specific to rheumatic diseases, part of the European. But it's where once you've had the vaccine, I think it's the consultants will have to give in that data. So just let them know about how you've responded. Let me see. Thoughts on travel in the summer. We're all so desperate to get away. Um, Again, a very personal view. The vaccine rollout has been absolutely top class here in the UK. It has not been so in many, many other countries. So personally, I'd be in no hurry to hop on a plane and go anywhere. Um, but that's a very, you have to sort of make that assessment of your own risk and your family's risk for yourself. And of course, it depends on what part of the continent you might be going to. If you're camping in France, as this person might be able to keep yourself very secluded from others, but it is still a risk. Uh,
So on a personal note, I'm sticking to my vitamin D in the form of tablets for this year. We are not going abroad, and I have no significant health issues.
yeah,
2 young children. We would love to, to escape to a hotter climate and have some proper sun, but we've decided, and it's just, I think it's really difficult. We are all adults, and people will decide for themselves. But Claire, you absolutely, hit this on the head before with your comment. We're not safe until we're all safe.
yeah,
We are doing very, very well in the UK, but my God, there are some countries who are really struggling.
there are
And
indeed.
I think it's so, so sad, and I think it is, we are very, very, very lucky here. Um but one of the things is that I do feel that there's a level of responsibility almost for us,
Mm,
to help our society. And I think one of the challenges with travel and airports and such is just the logistics of putting people in a confined space for quite a
yeah.
number of hours, and then mingling with lots of people from other flights and
Mm.
such. It's just like and always like a massive petri dish of all the.
Yes, it is.
So
And
it
the second
is.
part of that question is, can we ask for a letter to help claim and cancel, through the insurance? Um, I would urge you, no, we can't provide you with a letter for that, and nor can your rheumatology units. That's not ideal, really. So, it is unfortunate that you may have lost money on a cancelled holiday, but I
But there are
think the
quite a lot of
travel
companies.
insurance companies are trying to avoid, but
Yeah.
many of them are, some are better than others, of course, with offering to rebook
Mm,
even for next year. Just perhaps persevere and try and get that booking
yeah.
pushed on till next year. Let me see. You'll see video on how to see. Oh yes, somebody's commenting on the Remora. Um, I think that is very useful. Yes, the link is on our website, but we will get that put on uh, Facebook at a later date. But also, there is the Know Your DAS app if you're somebody who likes to have an app on their phone, which also shows how to examine your joints and then keep track of it as well, and keep track of your disease activity score. So again, the link is on the website to that. Is it safe to go to the spa? I'm assuming that means like jacuzzis and all that, and here in the UK. I don't know really. I suppose
Well,
I
I
think
think like everything, it's, going to swimming pool, going to a gym, it's, I put them in the same sort of, all of these companies and health facilities and leisure centres that are opening up have had to make sure that they are COVID secure, and follow. And I think it's fair to say we know that some places are maybe slightly better than others as to how they police that. So I'd say to lots of my patients, if you're thinking about going back to swimming pool, go and put your mask on and and see how they're doing it, or have a chat to them,
yeah,
and then make your decision, rather than, right, I'm going swimming today, and then turn up and go, oh my goodness, I do not feel comfortable in here.
mm,
So I don't think there's anything wrong with going for a bit of a, it's a bit like the advice I give to patients when they're thinking of trying out a new gentle exercise classes. Go and watch your first one, see
yeah,
what it's like, and then join it. So I think people have been, and I'm seeing this with lots of my patients, even though they've had both of their vaccinations and obviously rules are relaxing, people are still understandably very
mm,
nervous. I've stayed safe for this long, and I don't want to risk it.
yeah,
So, and it's not as if on the 21st of June, if everything goes to plan, suddenly COVID's not, it's going to be around us still. It's
yes.
just there will be much less of it that we can start to hopefully return.
And I think as well, not giving in to some peer pressure,
Yeah.
even from families, very well-meaning friends and family, etc., saying, "Oh, come on, it's okay now. You can come out to the restaurant," if you're not comfortable, being around because after such a long time of not being in crowds, that can be quite a disconcerting feeling.
Mm,
And trust yourself, I think, is the message.
mm.
Don't it, people will want to socialize, of course they will. They'll want to see you, um, but do it in your own time when you're
Yeah, and make
ready.
sure you feel comfortable with it. I remember one of the first, well, I remember actually, I think the first webinar I did for NRAS being very emotional, saying this is a huge ask of our patients to stay indoors and stay safe. And I remember at that time feeling quite, my God, this is a lot to ask. And,
Mm,
we never thought it was going to go on this long. But
no.
I think equally now give yourselves permission to gently adjust back at a pace that you feel comfortable with and
Hmm.
in ways that you can, if you're nervous, you can be in control of that situation. So
Yes.
going out suddenly to a restaurant you've never been to before and sitting yourself down, it's probably not the way. Go to somewhere you're familiar with somebody who you know has been safe and sticking to the rules, and just ease yourself in gently.
Yes, I think that's it. Just a few more quick questions. Loads of messages coming in. I don't think we're going to get round to answering them all, but so we'll keep these. This will be the quick fire round, okay, Lizzie?
I don't
Quick
do
fire
anything
round.
quick fire.
Um, Somebody who has stiff and unable to move their shoulder joint or their wrist, are they better off taking ibuprofen rather than paracetamol if it's
For the
stiff and
vaccine or
no, no, no. This is not about the
oh,
vaccine.
just
This
oh
is
right,
just a
oh,
general
just,
RA question.
we always say if you're having a flare of your arthritis and you can safely take an anti-inflammatory, I would always encourage patients to take an anti-inflammatory. But you can take, but they complement each other. So if you're struggling, you can take both.
Somebody asking long COVID and RA symptoms are very similar. Is there any value in studying this and learning and sharing info, etc.? I think again over
Oh,
time a lot of this data will
so
be.
yeah, the post-COVID story is a big one.
Mm,
And I've been involved locally on our patch of setting up the post COVID service or the long COVID. I don't like long COVID because how long's long? I
yeah,
think post COVID syndrome is a better way of putting it, and acknowledging people struggle in different ways because of how poorly they've been being in hospital and such. um, um, so there is, just to give everyone reassurance, huge amount of data being collected on patients being referred through to post-COVID syndrome services so that we can understand the condition, other conditions that patients might have, as well as now having post-COVID
mm,
symptoms. So be reassured, it's the one bit that we are robustly collecting data from the start on, and about other risk factors that might mean people are more at risk. So there's a lot of stuff going on, and it's a requirement of any of those services to collect that information.
great.
So we will
So,
hopefully start to understand more about the longer term effects following COVID infection.
exactly. Thank you so much. Very quick one here. Does turmeric give any benefit to RA?
So I love turmeric. I'm a great believer that we don't know all the answers. I'm probably going to say something very controversial. It's a natural anti-inflammatory that's been used for years. And I say to patients, look, if you want to take turmeric instead of taking an anti-inflammatory, please don't take it instead of your methotrexate or your etanercept or your other medication that we prescribe. But if you need, and it is a naturally occurring substance. So I say to patients, look, I don't know all the answers, but I don't have a problem with you supplementing it with your painkillers. Might
Yeah.
be a bit controversial. You might not get all your medical advisors to take that line, but
But again, it's it doesn't have a contraindication with
no,
any of the medications.
yeah,
If you take something like turmeric and it makes you feel better, feeling better makes you
yeah.
RA fit. What harm?
Yeah. But
There
please
isn't
don't
any
substitute
real.
the methotrexate. So take your
No, 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 no.
methotrexate, but it's the sort of to complement. And I
Exactly,
do
and
say
that's it,
too,
complement,
yeah.
not alternative, because there just isn't the evidence. I'm afraid I can't answer the question about whether self-catering cottages in the UK are cleaned well enough for us to use. It will vary. Go look at the reviews, I would suggest, and see what other people have said about the cleanliness before you book a holiday in a self-catering cottage. I just went on one recently, Airbnb. perfect, but that was just me.
And
Uh,
take your own stuff. Take your own stuff to clean it. So get
yeah,
in there, put your gloves and your pinny on, and give it a good once over. That's what I
if
said
you're
to my mum.
concerned.
If you're worried, take your Dettol yourself and do it yourself the moment you arrive, and then off you go.
Da, da, da. Somebody's asking here, concerned that when no face-to-face appointment, that there could be a tendency to over-rely on blood test results.
Mm.
Um, Again, will depend very much on
Yeah, bloods are
the,
part of our assessment, and without a doubt, if we've been worried that someone's flaring, we bring them in and we properly assess, and we have that face to face.
yeah,
As I said, I know I'm very, very fortunate being a community-based service. We have been able to get our outpatient departments, and I know lots of my colleagues up and down the country are really struggling because hospitals have really struggled with their outpatients. So just
hmm
be kind to your rheumatology teams that, well, Dr. McPhee's seeing her patients now, most of them.
yeah,
And patients are all given the choice. If they still don't feel comfortable about coming, then we say, look, we're happy to do a telephone, but if you're really struggling, there might be limitations as to what we can
yeah.
do over the phone. So it's just managing those.
And somebody's asking when will face-to-face start? Again, it has started in many places.
Mm,
It didn't stop in some places. It
yeah.
really does depend on the rheumatology unit you're under. So that's a message out to Loretta. And mental health, of course, is really, really important. I think, if your mental health hasn't been impacted in any shape or form by COVID, then I would be more worried about you. I think everybody has had real dips in emotions, and it's been hard.
Mm.
During our RA Awareness Week in September, we will be doing our well-being and mental health sessions again. Do keep an eye out for that. Um, and it is really important. Of course, our peer support can be very helpful as well. Sometimes just talking to someone outside of your own family who knows what it's like, what you're going through, can be a great help. And there are some really excellent online support as well for psychological support. So do again take a look at our website for further information, or give our helpline. I'll give our helpline a little plug now. They'll tell me off when the phones go ringing tomorrow crazy. It's 0800 298 7650 for our helpline, and they'll be able to guide you in some way to where you can perhaps get the help you need. Do we need the booster vaccine? I think yes,
Yes.
more than likely. There's discussion again on the vaccine minister was saying they're certainly getting all the supplies ready for the vaccine. And I will just open up the document so I'm ensuring that I'm saying the right thing here.
I think
Uh,
that it will be rolled out. Our understanding is very similar to how they did the categories first time round. So people will be
yes,
prioritized, which makes complete sense. And please, 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 vaccines only last for so long and they constantly
so you
have to
will
be
need the booster.
adapted because of variants. Though at the moment, it looks like all the variants that we are aware of are responding to the vaccine. So that's good news.
So from the
Um,
meeting the other day, it was, and there is a study underway into which vaccines work best as a third booster. Initial results trialing 7 vaccines. So there's seven vaccines, and they're expected in September. The NHS is preparing for a possibility of a booster program, and they are looking into the possibility of combining it with the flu vaccine. So you might get the flu in one arm, COVID in the other. Again, early days, but it'll save people trying to make 2 appointments. And the decision about whether to include groups 1 to 4 or 1 to 6 in the booster program will be based on the advice from the JCVI. So it's not decided yet, but as soon as we know, we'll make sure that you guys know. So that's still coming on. And I think I'm going to have to make this my very last question. Um, do you know how many people developed a? This is again not a vaccine question. This is or a COVID question. This is around methotrexate. Do we have any data about how many people develop a cough with methotrexate? Again, methotrexate can be one of those where
mm.
there can be an issue. Their husband has had one since he started methotrexate 2 years ago. I would say you need to have a conversation with your rheumatologist about that,
Yeah.
definitely, because there may
So
be something. Don't
yeah,
want to panic you, but just worth checking out.
there is a nasty and serious problem that can occur with methotrexate in the lungs, but you wouldn't grumble for 2 years with a cough with it. So that's so reassuring. It won't be that, but I think it's worth speaking to your rheumatology team just to unpick and get some. Hopefully, I hope would be reassurance around that.
Yeah.
But yeah, it's we always advise patients a new onset cough after starting methotrexate. Give us a ring on the advice line, please. So, but
Certainly well
but
worth
what
checking
I'm
out.
worried about will not have been going on for 2 years, so you don't need to panic and be tonight. But yeah, get in touch with your team and have a chat through with them. That's what they're
Well,
there
I
for.
think we've gone through so many areas of interest. I hope everybody that's been watching has found that useful. Again, we'll be doing the next general Facebook Live will be the last Wednesday of next month. There is a JIA one tomorrow evening with my colleagues looking at pediatric rheumatology, etc. So do tune in for that if that's of interest to you. Thank you to my colleague Ariba, who's been working on sifting through all the questions for me and posting them. But a huge thank you to Lizzie, who can now go relax with your family, have a nice dinner, and please keep it on behalf of everybody that's been watching this evening. Thank you so much for your expertise and your knowledge. I really appreciate it. But also on behalf of your own patients, thank you for all that you do and all your colleagues do for people with RA. Really much appreciated. And thank you so much, and we'll see you next time on
Oh, it's
Facebook
lovely
Live.
to be back and a privilege and a pleasure to be one of your advisors. So thank you.
Thank you. Take care, everybody, and stay safe and get that vaccine. And as they say, stay negative. That's what we want for everybody. Take care. Bye bye. Good night.
Night.